Good morning, Endometriosis Summit crowd, but more importantly, extra pelvic not rare. Good morning to all. We are here sponsoring a very special webinar that really we had nothing to do with except to load our Zoom account. So I want to welcome Wendy Bingham as she presents this amazing experience. Wendy?
Thank you, Sally. Good morning, good afternoon, good evening, good night to some people, wherever you're tuning in from around the world. We're here with Dr. Abhishek, Mangeshikar, and he's coming from Mumbai, and I'm coming from the West Coast of America. So welcome to everybody halfway around the world and all the way around the world. I have a few housekeeping things this morning. First off, I want to thank Dr. Sally Sorrell and the Endometriosis Summit for hosting this and giving us this platform. It's lovely to be able to partner with them and bring more education to our community, as well as to any physicians or healthcare practitioners and providers that might be out there tuning in. I also want to give a special acknowledgement to people that are still continuing to suffer with COVID and the pandemic, particularly our friends in India. You're in our hearts. I know that it's a pretty serious situation there, and I give my hope to everybody there, as well as our friends in Canada who are still seeking to get vaccinations. I know it's been a very slow rollout for you. Before we get started, I wanted to let people know that Sally and I brainstormed and figured out how to work the closed captions. So if you would like to have this translated into written language, if you go to your navigation screen at the bottom, on the right-hand side, it should say live transcript. And you want to click on live transcript, and you want to scroll down to, what was it said? The settings. There you can click on, it'll say live. And when you open that, once it'll translate, you can also increase the size of the wording on your screen. If you don't want it, you can hide it. Also, what Dr. Mangeshikar and I would prefer is if you have questions, use your Q&A that are questions directed to the panelists. Otherwise, please use your chat section to chat along with anybody else who might be attending. So that will make it fun for you. We also have a few polls that we're going to launch today. So other than that, we are about to get started. So I'm going to do a little bit of an introduction to what we're doing, an outline, and introduce our guest speaker today. And we will banter back and forth a little bit. We both have slides that are integrated together. To keep things moving, you'll see us using the slides and going back and forth. So let's begin. Right here with, let's see here, I got to move you all the way back up to here. So this is our introduction. Dr. Sally Sorrell made the beginning section for us here, so she did a lovely job with our graphics. Our first poll today that we're going to take before we start, I know that people are still joining us, is a survey. So I am going to, let's see here. We go to the poll.
It's launched. I have to launch it because it's my account.
Okay, so go ahead and launch the first poll. It's still pretty early, so.
So Wendy, you're looking at 17% from Europe, for about 43% from India, yay, 13% from the UK, and 25% from the United States. And then there's someone from Egypt as well. So I'm going to go ahead and end that poll.
Wonderful. So hopefully we'll continue to get people coming on board and listening in. Yeah, thank you for sharing that, Sally. So that's good. Okay, so our objectives today, we have 6 objectives that we're going to go through, and Dr. Mangeshikar is going to talk about the first section, giving you an overview about surgery and aspects of having endometriosis. Then I'm going to briefly cut into giving an introduction about the digestive system, about the distribution and where you see endometriosis the most. And this will lead you back into Dr. Mangeshikar, and he'll be speaking about bowel endometriosis in detail. And then we touch a little bit on classification systems. There's a movement that we're hoping that will move out of the ASRM towards the what's called the Enzian classification. And that will bring us back towards imaging, because imaging is part of getting the validation of the classification system. And then we end with just some observations that we're seeing that are they're observations, but they're not really not enough scientific data on it consistently. So our guest speaker is Dr. Abhishek Mangeshikar, and he is the director of the Indian Center for Endometriosis in Mumbai, India. He is a third-generation gynecologist, born and raised in Mumbai, and he treats patients from across the world. He does get quite a few international patients from Canada, the United Kingdom, and Africa. He's a board member of the Asian Pacific Association of Gynecological Endoscopists, and he's an adjunct faculty member for programs in both Mumbai, India, and in Germany. And he is a faculty member doing workshops in Taiwan and China. He studied medicine in India. He did a 2-year MIG specialty in Taipan, Taiwan. His original focus was oncological gynecology, which is actually very fascinating to talk with him about the transition from oncology to endometriosis. When he returned to Mumbai, he saw that there was a great need for endometriosis specialty more than oncology, and he has a strong interest in bowel endometriosis. When he transitioned from oncology to endometriosis, he did further training with Horace Roman in France for bowel endometriosis. So I'm going to turn the table over to Dr. Mangeshikar, and he will start us off on the pitfalls of endometriosis patients.
Thank you, Wendy, and Dr. Sally Sorrell and the Endometriosis Summit for hosting this event, and especially to Extra Pelvic Not Rare for helping shine a light on not just bowel endometriosis, but all different locations of endometriosis, which Dr. Bingham will talk about a little later on. So if we want to get started, are you sharing the PowerPoint or should I?
I turned my section off. You can pull yours up.
Yeah. So let's get started from here. All right. So we know that endometriosis is got the problems that it already has and why these problems are there. Most importantly, there's a failure of support systems, whether they are familial support systems or social support systems, as well as the medical support systems that are supposed to make the diagnosis and correctly and accurately and provide the necessary treatments. But a lot of these patients are met with medical and familial gaslighting, where they're labeled as attention-seeking, narcotic-seeking, frequent flyers, drug-seeking behavior, or attention-seeking. And then a lot of women in pain are neglected treatment until they are ready to probably reproduce. And there's a greater focus on fertility than there is on pain, which is a bit of a tragedy. And that needs to change, as well as you see papers coming out addressing the gender pain gap, that men in pain are paid more attention to than female patients. So this was a paper by the BBC. It was a research publication in 2019 that looked at the quality of life of women with endometriosis. And they were found an 84% decrease in quality of work, and 1/5 of them reported temporary disability. And another 40% did not achieve what they wanted to career-wise because of chronic absenteeism and the inability to perform to their optimum potential. 3% reported total incapacitation at some point, and 1% attempted suicide, although I do suspect that that number may be higher, because it's still a lot of women and patients of endometriosis may not be comfortable talking about that, and there would be gross underreporting. So when we talk about treatments, hopefully this would be laid to rest with there's the medical suppression therapies to control symptomatic treatments, and there's surgical, which is a more immediate effect of actually removing the disease focus, which would have a greater long-term benefit to the patients. So medical, just to brush on quickly, is like trying to control an arterial bleed with a Band-Aid. So it is a temporary fix if you want to control symptoms until the time you can direct the patient into getting the surgery at the specialty center. For example, in a pandemic, when patients are unable to travel or hospital resources may not be available because we have a shortage of ventilators, ICU beds, oxygen, and even OR staff. So yes, in those cases, medication is beneficial in delaying surgery and maybe a good adjuvant therapy post-operatively in very certain cases. But of course, especially for bowel endometriosis, the mainstay of treatment is surgical. And we know this, that, and since I have personal experience in both, I can tell you it's more surgically intense than oncology. There was a paper by De La Hera Lazaro that showed that surgery improved quality of life, where when we look at visual analog scores for pain preoperatively, were an average of 8.5, and postoperatively, the patients were followed up and had a pain score of 1.4. So that is a dramatic improvement in intensity of pain, as well as the number of days the patient suffers pain, which is what a great mainstay of treatment should be. Just quickly to brush on, we know that there's enough evidence now that excision is the mainstay of treatment, but you see the term excision being thrown around a lot nowadays, where there's a difference. If you look at the bottom side, there's a difference between doing proper excision, especially with bowel endometriosis. You have to kind of understand that excision involves removing all the disease, and you just don't need to give the tiger a haircut. You need to actually cut the head off before, or you get caught with the tiger's tail in your hands. So there is a great need for specialization in it. We, Dr. Bingham and I had huge discussions about, and we're on the same page, that O and G should separate as specialties, and even within the G, there needs to be a subspecialty for endometriosis. So, you know, just like how ovarian cancer outcomes improved dramatically once there were multidisciplinary teams dealing with ovarian cancers, I think endometriosis would greatly benefit from the establishment of specialized centers, as well as a different subspecialty specializing in endometriosis. So obviously, you wouldn't allow a general surgeon to operate or even clip an aneurysm in the brain. So why would you allow a general baby catcher to deal with a disease that is significantly more complex than oncology cases? So, which brings us to who should operate. Should it be urologists doing urethral endometriosis? Should the general surgeons be handling the bowel endometriosis? Should it be just under the realm of gynecology? Should it be done by a fertility specialist? Or should it be done by gyne-oncologists? So the answer is not either or. It's more about involving everybody. So the different specialties need to work together, because it's not just under the realm of gynecology. We know, of course, that it is affects organs in the pelvis, but it also affects organs outside the pelvis, all the way up to the chest, the diaphragm, and probably even higher, which Dr. Bingham will go through later on in her presentation. We know that there were inadequate treatments when they were studied, had huge recurrence rates, and it is obviously birthed the era of the laparoscopic pelvic surgeon. This is going to require high volume centers focusing on endometriosis with a multidisciplinary unit in place. This is not just surgical specialties. This also requires adjunctive therapies as physiotherapy, nutrition, counseling, sexology. And if there's a role for fertility, then we need fertility specialists and a whole bunch of other specializations to kind of holistically treat this patient. And of course, there is not one size fits all. You cannot do the same surgery for every patient. The radicality of the surgery has to be tailored not to your comfort as a surgeon, but it has to be tailored to the patient's disease, and it has to be tailored to the patient's needs. You cannot excise huge parametrial nerve disease and leave the patient incontinent and requiring self-catheterization for the rest of her life. So we have to kind of tailor each case and our approach to every patient. So making the diagnosis, I think, is the most important step in treating endometriosis. And this is also circling back to why we need to separate O and G, because if you're seeing an ANC outpatient where you're seeing 20, 30 patients a day, you are not going to be able to give the required hour or hour and a half to the patient of endometriosis, which is how long it takes to make the diagnosis, just from understanding her voluminous probably history that she's been through multiple doctors, multiple loads of symptoms, and you have to pay attention to the types of pain and the location and the variations in pain, especially exacerbating and relieving factors, that is going to give you a mental map of where to look for disease during imaging and surgery. So a detailed history is very important, and one should spend a lot of time there. If in my practice, a lot of patients have had previous surgery, so I try to go over their records as meticulously as possible with a fine-tooth comb. And examination is very useful, but understand that these patients have tremendous pain, so it may not necessarily be possible in the clinic setting. And of course, imaging has its role, but imaging is not absolute, which we're going to discuss later on. So a pelvic examination is important, and if it's possible, you can try to do it with one finger. But if the patient has pain, it's not wise to proceed with the examination, and one can possibly conduct the examination under anesthesia, probably before initiating surgery. One can perform a simultaneous pelvic and rectal exam at the same time to assess the rectovaginal septum. And it's not, and a small tip is it doesn't help to tell an anxious patient to relax. What you do is kind of instruct her how to relax. So to let the knees go floppy and to not lift the pelvis off the table is a great way to kind of earn the patient's trust and to help them relax rather than actually saying the word relax. I think I can switch over, or would you like to just continue from my presentation?
I'll continue from yours if that works smooth. There was a question about this being recorded and posted later, and yes, this will be recorded, and Dr. Sally Sorrell will navigate the logistics of that, and as soon as that becomes available and we're able to post that, it'll also be posted in my group for information of where to access this. So having said that, we'll move forward. I wanted to clarify to people, there's a variety of definitions of what is considered extrapelvic endometriosis. There's a variety of words used, for example, endopelvic, extragenital, and extrapelvic disease. We actually did a survey on this when we were first creating our name, and it's the preference of people with endometriosis that prefer the term extrapelvic endometriosis. It moves away from genitalia, as well as making some reference to exactly where the disease originates from. Since at this time, it's not confirmed where the disease arises from, we choose to use extrapelvic endometriosis. So having said that, there's a few well-published people who have used the term. So I'm going to go back to Markham in 1991. He described the difference between those as pelvic endometriosis is specifically focused on the uterus, the fallopian tubes, ovaries, the surrounding peritoneum, and the front and posterior cul-de-sacs and the sidewalls. So this also includes the ligaments of the uterus. Extrapelvic endometriosis basically applies to endometriotic-like lesions elsewhere in the body. So this includes the digestive system, the urinary system, the respiratory system, the cutaneous system, the muscular system, the nervous system, and so forth. Next. Basically, what I did is look a lot through the literature, and today we don't have very good statistics on exactly what the prevalence of extrapelvic disease is. There's an approximation average of being about 20% or 1 in 5 persons with endometriosis. This ranges up to, I have seen as high as 37%. If you were to ask my personal opinion, I'm not a surgeon. I don't work in a high level surgical center, but we also know that there's a lot of misdiagnosed and undiagnosed disease out there. Further, that these people that have disease that go elsewhere, that we don't have very good tracking from a national to an international level to record all of the episodes. So to me, I would believe 35 to 40% of those people with endometriosis also have disease elsewhere outside of the reproductive organs and supportive structures. Next, Dr. Mangeshikar. When we look specifically at the distribution of endometriosis with digestive system, the literature again ranges between 33 and 37% of women with endometriosis have disease of the digestive system. But the approximate range, and I was talking to Dr. Mangeshikar about it being approximately 12%, it seems to be the going rate in the literature. The large intestine is the #1 location of disease, and the most common areas is the rectum and the sigmoid colon. If you were to go stepwise down, then you would see that the small intestine is second. So I've taken it upon myself to do extensive database searching of all databases I could find with literature published in English. There you will see that you have more liver, then it's followed by a few pancreas, very few stomach, gallbladder, and esophagus. I again will say that this is the literature. We do not know how many unpublished cases there are out there, nor do we have any way to track them. It's most interesting is I do see people in my support group that do have documented cases of disease in these less common areas, but they're not in the literature. Next. So we did an infographic to demonstrate at a 12% rate, if you had 100 individuals with endometriosis in a theater watching a movie, these are the people that you would on an average estimate to have endometriosis of the intestinal tract. Predominantly 85–90% would be in the rectum of the sigmoid colon. Again, we don't know the prevalence. It could be much higher than this, or it could be as low as 5%. The next. So when we looked at the distribution in the large intestine, according to the literature, what we're seeing is a progressive, first off, there's predominance in the rectum and sigmoid colon, as well as the rectovaginal septum. And it's less frequent in these particular areas, the appendix, the terminal ileum, the cecum, and then various parts of the ascending, transverse, and descending colon. Next. They were estimating, I noticed on the Indian Center of Endometriosis site, they estimated 25 million people have endometriosis in India. So I took it upon me to say, well, how many would possibly have bowel disease or intestinal tract disease? And this can range from superficial to deep disease. So if you were looking at 5%, that's 1.25 million people in India alone. If you were to look as high as 20%, it's 5 million people. So if we're saying the average rate that they perceive is 12%, that's 3 million people in India alone. Now, of those, we know that that distribution can range from very minimal to disease to very, very deep disease. So who do we have to take care of those people? So we're going to do a survey here. And Sally, are you able to post up the survey for us?
I gotcha.
Thank you. So what we're going to do is we want to put a survey up just to see who in the audience is able to answer these questions. If you go through, I think there's 6 of them.
We have some questions from Facebook. Do you want to hold them or do you want to answer them while people are answering the poll?
Who are they directed to?
They're really generalized questions. I think maybe till the end.
Yeah, that sounds good. Yeah, thank you, Sally.
No one is answering this poll. I don't know what's wrong.
Oh, it says hosts and panelists cannot vote. We're working out the kinks. Bear with us.
Can we stop the screen share for a moment? It's not, I mean, I can, yeah, there you go. Now people are answering.
That's it.
Much better.
Technology.
Okay, so we'll give since we just figured it out, we'll give 15 more seconds and then we'll share the results. Because this was a long poll, I think.
I think there's 6 questions for the second and third poll.
Yeah, but just another second.
Let me see here.
Okay, so I'm going to share the results.
Symptoms, but no diagnosis.
Lots of rectum and sigmoid disease.
Yeah. It would be wonderful if people were able to take the poll in the recorded view, because you know that's people are going to come and look, but they won't be able to participate in the polls.
Well, we can where am I? We can sort of figure out we could run it off your website or off the doctor's website. We could get the polls a different way, probably with a plugin.
Yeah, I mean, it is being a Saturday. It's a day that a lot of people are out, and so they are going to want to watch this later, because I had them question that a lot of my group.
Right. So you can go back to your
sure
slides.
Yeah.
All right.
Okay, so the slideshow gave us the poll was to give us an idea of who's in the audience, but it also gives a good perspective of where we are, because what we see in the literature is being reported, and we want to know what real time is of what people are experiencing. So back to you.
All right, thank you. So we're going to talk about imaging now. It's, of course, ever so recently gotten into a bit of controversy. But as a surgeon, imaging is important to me to help plan my surgery. So what we need to know as surgeons are whether how much length of the bowel is infiltrated. This is going to help us mainly decide if we're going to do a segmental resection or a discoid excision, which I'm going to talk about a little later, so don't get thrown off by the terminology. We need to know how deep into the muscular layer of the rectum is the infiltration. And of course, if there is any infiltration into the vagina, which is going to increase risk of complications, because those will have 2 suture lines overlying each other. And of course, the closer the nodule is to the anal verge, increases the chances of postoperative complications and possibly a compromise of the rectal function. So the closer we are to the anal verge, the more conservative we want to be surgically. And if there is a lateral infiltration of the nodule, which is towards the sides, is where all the nerves supplying the bladder, the vagina, and the bowel run, is going to also determine, especially if you've got bilateral infiltration, is going to have a lot of complications regarding continence of the bladder and the bowel. and also sexual function. So these are important things you need to consider and discuss with your patient before surgery. So I think that's what the surgeons need to know before going into surgery and planning their treatments. So just a little bit of a quick anatomy lesson. So this is a cross section through the bowel, the large intestine, for our immediate purposes, the rectum and the sigmoid. So when the outer ring is the serosa, which is just a peritoneal covering of the actual rectum. The larger red concentric circle is the muscularis layer. So it's a muscle layer. This is usually the layer in which there's infiltration of the disease. So this is the layer that increases in size. Very rarely does the disease actually traverse these layers and end up into the lumen or the mucosa of the bowel, which is why a lot of colonoscopies are negative. All right. So when there's infiltration of the muscularis layer into compressing into the mucosa, but not breaching the mucosa, is where we get our percentages and how much occlusion or blockage of the tube there is. So going backwards, when we have up to 50% of occlusion, and if the length of infiltration, of course, this is a cross section, so you can't appreciate length here. So these are the three conservative options, apart from a segmental resection, where a discoid excision is possible, but it is a full thickness excision, but not removing the posterior wall of the rectum. So you're not losing a segment, and you're also much more friendly with the nerve function or nerve preservation with this procedure. A mucosal skinning is just a deep shaving. So when you remove the entire muscularis layer up to the mucosa without opening the rectum is mucosal skinning or deep shaving. And shaving is, of course, suitable for giving a very superficial nodule a haircut. But shaving, safest procedure, highest rate of recurrences, around 8%. Segmental resection, most radical of the procedures, but lowest rate of recurrences, less than 1%, and highest rate of complications. So of course, like I said before, it's not about what you're comfortable with, it's what the disease and the patient require. So to go over them quickly, shaving is just removing the disease without breaching the rectum. And you can use anything. You can use cold scissors, you can use monopolar scissors, you can use lasers, ultrasonic devices, or even plasma jets. So discoid resection is when we use a circular stapler through the anal canal and fit the nodule between the stapler and just do an anterior full thickness discectomy. A little better explanation. So if you look at this cross section, this is the nodule here, which is, so it kind of turns the nodule into a calzone pizza. It folds the rectal wall upon itself and fires a circular stapler there. Very similar to this laparoscopic image, which is, I believe, a few surgeons in the United States do this. They do a laparoscopic excision of the nodule, full thickness, and then repair it laparoscopically or robotically via hand suturing. We use the stapler, and both techniques are equally effective. It's just what you're comfortable with and how you're trained. So that's about the disc excision. So segmental resections, of course, were the primary technique used to remove complete disease. It's a very radical technique. And colorectal surgeons, when they're trained, are trained to do this for colon cancers. So the length of resections, what you do for colon cancers, about almost a foot of bowel is removed. But of course, endometriosis is a benign disease. So we have to tailor this just to maybe 5 millimeters above the lesion and 5 millimeters below the lesion, and remove as little bowel as possible. And we can be as close to the bowel as possible because we don't need to take lymph nodes or nerves out with these procedures. So one would have to be as conservative as possible, even with this radical option. And I see a lot of publications moving towards that. So that's a great thing. Of course, like I mentioned, most radical procedure, lowest rate of recurrence, but highest rate of complications. So we have, of course, fistula, any leakage of the anastomosis is our greatest fear. And I think the rates of that are about 4% to 6%, depending on whose data you look at. And that's it for surgery. We're going to talk, Dr. Bingham is going to talk to you now.
Yeah, thank you. So basically, we were talking about how we don't know what the prevalence is of disease, extrapelvic endometriosis. Some areas are much more common, so we see higher rates in the literature. But what we notice is that there's a barrier from the bottom up or the top down, and trying to address the different obstacles to trying to get a better estimate of how common disease is in these areas has been a real challenge. It's necessary for us to have better statistics, because statistics is what drives change. And part of that change comes with increased awareness through research that's being conducted in these particular areas, as well as accessing resources and developing these specified centers. So there are 3 different levels. One is the top, and this involves the ability to record every episode of disease. As I mentioned, that we don't have a good way of tracking disease. The current way that we do that is through the International Classifications of Diseases. This is run by the World Health Organization, and well over 100 countries around the globe use the ICDs to track mortality. So these are things that cause death among people. And so they track episodes of this. A smaller section, which tracks morbidities, and these are conditions, diseases that we live with, are used by 27 countries around the world. Right now, endometriosis is classified in the morbidity section. However, it's very limited to what areas of disease are classified. So when a doctor gives you a diagnosis of endometriosis, they will go into the ICD codes and they will record, oh, they have endometriosis. And then there are subcodes to tell you where they have endometriosis. This is where we're running into problems with disease outside the reproductive area. So there are very limited areas, and I'll go over that briefly. The middle section is basically the intermediate of having organizations, say, for example, the American College of Obstetric and Gynecology, the organizations in Europe, throughout the world, as well as specialties like AAGL, finding ways that they can come together and collect episodes. There's been a proposal by the AAGL last year, and I was talking to Abhishek about this, and he had mentioned in the past, prior, it's been brought up over and over, how do we start collecting this data? There was discussion about creating a larger database from international surgical centers, submitting the information, all the episodes they collect of disease from their center. This is a good step forward, but it also is very limited. It's limited to the data they have from individuals around the world that are able to go to those specialty centers for care. So that will exclude a large percentage of people around the world. Plus, you have to consider the people that are misdiagnosed or undiagnosed with disease. The bottom tier right now is probably the best chance we have of at least getting someplace. And this is to do with the individual way that surgical centers, which many of them do track their own statistics of episodes throughout the body, but to improve it across the board to use what's called the Enzian classification system. So are you able to go to the next slide?
Sure.
Thank you. So currently the individual surgeons use commonly the ASRM, but there are pockets, particularly in Europe, that are using the Enzian classification scheme. They're also recording those through medical records. And with that, each surgical center tracks their own data. And go to the next one. So the middle tier, again, is the proposal that was offered. And this is an example is last year at the AAGO virtual conference that they said, let's create a database. And we see that the database will be a good start. But again, we have to be considerate of, is the data that's collected from these surgical centers representative of the global population? Because we only know that there's only so many surgical centers that will be participating in this around the globe. And it also will not include people that are misdiagnosed or receive care from another surgeon, another non-gynecological surgeon that sees the disease, because they will see the disease, but they have no way to document it. Because a lot of these areas in particular, with the exception of intestinal disease and cutaneous scar endometriosis, everything is classified as other. So with the next one. So this is a very, very busy slide, but all I want to do is draw attention to you. This is what's called the ICD classification system, and it is operated by the World Health Organization. It's under its 10th version right now. The importance of this is to show people that aren't in the medical system how complicated it is to get an idea of where to start. How do we know how much disease is out there? If you look to the left, this is currently the ICD system that's in use. If you scroll down and you see in red, those are areas in particular that are acknowledged of, let's say, intestinal and secondary cutaneous endometriosis have their own code. So they're being documented. Intestinal disease isn't being documented per which section of the intestinal system, but at least it has a code. Everything else, bladder, ureter, oh my gosh, diaphragm disease, everything is classified under 80.8. To date, we don't have anything set up. There's no statistics released from the World Health Organization about endometriosis. So I can't even access that out of the 27 countries. What kind of statistics are being offered that they're collecting to show us this? If you go to the right, the 11th version has been worked on since 2017, I believe. To date, these are the modifications that have been made. If you scroll down, you'll see that deep endo needs more clarification. I was talking to Abhishek about this in regards to what he thinks deep endo might pertain to. Does it include urinary tract disease, the ureters in particular? You notice that endometriosis cutaneous scar is still present. However, we don't see primary. We don't see umbilicus disease, which is very common. Those things aren't tracked. It concerns me because when we think cutaneous scar, what do we think? We think transplanted endo, and we think endo comes from the uterus. It's my own personal thing of going back to the uterus again, rather than being away from it and just classifying it as it is. We still see endo of the intestine is still up, and we do have a new code for thoracic endometriosis. But there is no codes for the urinary tract, which is the second most common area. And it would make sense to me that that would be in place. However, they put in a code for salpingitis isthmica nodosus, which is not even endometriosis. So I'm unclear of why that's there in the system. There have been recommendations both for professionals. So if you are a medical professional and you are actively involved in endometriosis, the platform is open for you. So if you are an endometriosis specialist and you're watching this or you see the video recording of this, you can go to the ICD platform at the World Health Organization site and you can put in your comments and your proposals about what you think should be added or removed from this working proposal at the moment. Next slide. Now this is back to Dr. Mangeshikar. Where you go?
All right, the ICD was an eye opener for me because it's a mess, and as is the original or the long time standing classification system, which is the ASRM. And I was thinking about these two systems. Of course, there are a couple of other systems, but the most predominantly used is the ASRM classification. And when surgeons talk to each other, we're like, okay, I'm doing a stage 4 endometriosis. I have no clue what kind of procedure I'm going to do because it gives me no information except that there may be deep endometriosis, there may be partial or complete obliteration of the cul-de-sac, and there may be endometriomas. But I have no clue whether I need to have a urologist present. I have no clue whether I need to have a colorectal surgeon present, or if I need to have a thoracic surgeon present, because one, it only looks at pelvic organs, which is the uterus and the ovaries and tubes in this case. And I have in my opinion, it deals with only superficial disease. So this staging system, you would stage the disease when you would put the scope in and look. So when you see superficially what you are, that's what your scoring system is going to be. It has nothing to do with the deeper disease, which I think the Enzian system addresses a lot better, which I'm going to talk about in a little more detail. The original Enzian system was kind of negated by a lot of gynecological professionals because it was too complex for them to understand. Of course, if you're not doing the surgery and you've not seen that kind of disease and you don't remove that disease, you're not going to understand the reason behind the scoring system and why we need to document those particular lesions. So just quick pros and cons of the RSARM, which should be relegated to the archives of history shortly. And so when we talk about the Enzian system, I'm going to jump back and forth a bit. So this slide was the original Enzian classification. When they expanded upon it because of its shortcomings, it became the hashtag Enzian system, which is by the POT criteria. So that's peritoneum, ovarian, and tubal components. So the way it works is, let's look at the hashtag part of it first. So, and the interesting part of the Enzian system is that it can be documented via surgery. Of course, it has to be documented via surgery, but we can also compare our surgical findings to the documentation and the findings during imaging to kind of, one, improve the imaging, and two, to help in surgical planning. So, of course, in imaging, we are not going to be able to see peritoneal disease. So the P part of the system is not used for imaging. So ultrasound or MRI, Enzian classification does not consider peritoneal disease. It looks at OT, ABC, and F. So, but let's talk about the imaging, the scoring in general. So peritoneum is when there are peritoneal implants of endometriosis anywhere in the pelvis. And if the implants are less than 3 centimeters, cumulatively, it gets a score of 1. If it's between 3 and 7, cumulatively, it becomes 2. And if it's widespread, diffuse peritoneal implants, it's P3. Similarly, for ovary, because there are 2, there's right and left ovaries. So depending on the size of the ovarian disease, less than 3, 3 to 7, and more than 7 would give you a score of 01, 02, 03. And you can also mention if the ovary is missing in case of previous surgery, or if it's been retroperitonealized by like a remnant ovary syndrome or disease. Of course, what's very interesting is tubal classifications, whether they're adhesions, whether the tubes are mobile, the relationship between the tube and the ovary, which would have a great role in fertility outcomes, whether the patient would require to go into ART or would be allowed to try to conceive naturally post-operatively. So T1 is just ovarian adhesions, tubal adhesions to the pelvic sidewall. T2 is to the pelvic sidewall and the uterus, and T3 is uterosacral as well. So you would be very concerned about dissecting the ureter in these cases. So the imaging would need to pay special attention to that. And of course, the original Enzian system, which is quite brilliant in my opinion, and should be adopted, looks at, of course, ABC is your posterior compartment. And although I feel the F compartment could be expanded upon a little bit, but who knows, maybe in the future.
But it's there. It's there.
Yeah.
The start.
So the A looks at disease invading the back of the cervix, also known as the uterine torus, and disease infiltrating the vagina. So that's rectocervical and rectovaginal disease. Now the rectum may be just adherent to this disease, and there may be no disease into the rectum. So in this case, these cases, you could probably shave the disease off the rectum. But you would also need to excise the disease on the back of the cervix and the vagina. Now, this is A compartment is midline disease. It does not consider the lateral, which is the B compartment. So again, depending on the size of the lesion, you would score it 1, 2, or 3. And similarly, the B compartment, which is the most dangerous compartment now, looks at parametrial disease and lateral disease. So this is on the side of the rectum, invading where all the nerves and the big vessels supplying the legs kind of run through. And if you have a bleeding in this area, the hemorrhage is quite catastrophic. So there's a big deal of training, and nerve, especially neuropelviology, is an emerging discipline which deals with diseases in this compartment, which is, in my opinion, the most difficult kind of endometriosis to treat. So of course it's bilateral, so it gets left and right. And again, the scoring systems would help in talking to the patient about surgical outcomes and possible complications, post-operatively immediate and long-term. And finally, C compartment looks at disease in the rectum. So the size of the nodule, it doesn't really tell you how deep into that. So you would need to rely on your imaging, but usually a nodule more than 3 centimeters is not going to be very amenable to a conservative procedure. So you could try a big discoid resection or a double disc, but that is kind of pushing the envelope with a disc excision. And a conservative radical approach would be to do a resection in those cases. But I think that is of a more academic discussion. So the F compartment specializes where if you have adenomyosis, it becomes FA. If there's bladder endometriosis, it's FB, which you would need to know what kind of bladder endometriosis. And so I think that can be expanded upon. Also, the rest of the bowel, so appendix gets F appendix, F ileum or cecum gets the similar treatment, and ureter you would need to kind of know whether you're going to need to be able to just shave the disease off the ureter, or whether you would need to cut the ureter and do a reanastomosis or a reimplantation. And of course, F ellipsis for other endometriosis of the diaphragm, lung, peripheral nerves, what have you, muscle. So what's interesting about the engine system is that I think it is going to standardize the language of endometriosis communication between, not only between surgeons, but also between different specialties. So if imaging has to provide you a report specializing and denoting the classification of the disease, you would be obligated to treat that disease that has been picked up on imaging. Now, like we said, imaging is not the golden standard of diagnosis. At the end of the day, it is surgical experience and the clinical skill to be able to diagnose all the disease. So it must work together, which is why we keep on harping about the need for specialized centers to bring all these forces together to have for the greater good. But of course, to standardize the language of endometriosis and to make communication and data collection a lot more accessible and easier to interpret, I think this is a great step forward.
Abhishek, before we go to the survey, I got a couple questions. You want to go back to this?
Sure.
you and I were bantering about talking about how, first off, some of the syndromes that you could get Lars syndrome, that maybe that I think our audience would want to know a little bit about that, and the urinary type symptoms you could also get with bowel disease. So those two things. And then the last one was, how frequently is the ureter, given its location, if you have deep bowel disease, that the ureter could be affected. So those are three things. I think I'll try to remember those in my head as we go through those.
So those are great questions. So let me address, so just complications from segmental resections. And we know the short-term complications are leakage, anastomosis leakage. Long-term complications are LAS, or low anterior resection syndrome. So these happen when you do a very ultra low resection. Fortunately, in endometriosis, very few cases have disease that goes that low. So when we do resections, the best thing to do is, if you're doing a bowel resection, try to make sure your disease is high up. So you are.
Which means, can you explain that to them when they mean the low and the high? That might be helpful. I see you have a diagram here, like I think C kind of shows how low and high, to give them an idea.
So when I mentioned what we need to know during surgery, and the first thing is distance from the anal verge. So that, I mean, the imaging guys who do it are great at telling you, whether it's via ultrasound or MRI, they can tell you how far your lowest part of your lesion is. So less than 4 or less than 5 centimeters is considered, less than 4 is an ultra low resection. So you want to avoid having your lowest staple line that low. You want to hopefully end up with, if you're doing a segmental resection, you want the disease to be above that. It has long-term effects with forming of a pouch leading to chronic constipation. It can lead to an accumulation and loss of sphincter function, which requires a lot of neuromodulation and possibly stoma requirements, which is a colostomy bag or an ileostomy bag. And those are about the LAS complications. The more other complications, when we talk about lateral disease where the nerves run, especially if you've got a big rectal nodule that is expanded laterally, where it not only affects the nerves and it can also catch the ureter. So when the nerves are involved, the belief is that we're lucky that there's bilateral supply, and if you've got one side, the belief is that the other side takes over the function, so you're okay. But there was another paper that came out of Japan that said one side is dominant. So if you have a problem on the dominant side, the recessive side may not take up the conduction, and that might still lead to dysfunction. So we need a lot more research in that area before we have any conclusive evidence. And when we talk about lateral disease, the first thing you got to do is check your kidneys. If there is a hydroureter, make sure that the kidney is not compromised, and do not, for God's sake, put the patient on medication and tell her to come back after a year, because instead of doing a reimplantation, you're going to be doing a nephrectomy, which is, it's unfortunately more common than it should be. And these are young patients, and although there are 2 kidneys, we don't want to remove kidneys without, as far as we can avoid them. This is should be diagnosed early and dealt with expeditiously. Did anything else? What was the third part?
No, I think you did that. I think you got all 3 of the things I was thinking of. We do know, with the ureter, as you have hinted on, that there can be silent obstruction of the ureter, and that one kidney can take on the job of the other kidney with compensating it. So you're still having urinary voiding, you're still voiding correctly, because the other kidney's taking up the workload of the kidney that's now become progressively deficient. And some people don't have any outward signs or symptoms that would suggest that that's happening to them. So I'm glad you pointed those things out. Yeah, I think you got all those. Yeah. So I guess we're on to the poll, the next poll, right? Which goes a little bit more.
I'm coming.
Yeah.
Here we go. Poll 3. You think we'd get it by now?
No, practice makes perfect.
Okay. And let's give people some time to answer. I see on Facebook you're upset that you can't answer the polls, but so Wendy, do you want to read the questions and then we can pick some of the questions off of Facebook?
Sure. It says right now, though, they cannot vote. Now, he turned the screen share off, but now it says they can't vote. Is there, you want to try to, can you fix that?
So on Facebook, I don't think they'll be
No,
live.
on the imaging, I'm on mine. It says host and panelists. Oh, host and panelists. I guess I need to learn to read. Sorry. Yeah, I mean, do you have surgically confirmed endometriosis? You can say yes or no. We'll have to find a way to post this because this is really important
No,
information.
I've already been looking up plugins. Don't worry.
Oh, thank you. You're so sweet. Sally's on it. She's like super tech.
While we're waiting for people to vote, I just want to say this is one of the best webinars I've ever watched on this topic. And Dr. Vidali and I have been going back and forth on how to have the two of you make this into a workshop for Endo Summit workshop, because doctors and patients alike should understand that if you don't get the statistics and you don't get why all of this is important, then you're never going to have it be standard practice for a general surgeon to be in the OR. You're never going to have the coding system advance. You're never, I'm not sure how many surgeons in India really understand this information besides you, doctor. And we see what you're doing and we're like texting back and forth. How can we make this a workshop? How can we, so we have to talk about this. So now I have lots of people voting. And on Facebook, I would say probably 90% of the comments say that they have surgically confirmed diagnosis. The next question is, have you had imaging?
You know where we're headed with this, don't you, Abhishek?
Yeah. So I'm going to end the poll and launch the results.
Doing this on purpose because we need to see what reality is like in the real world versus publications. I mean, we know that objective information, data driven from research, and what is published out there is really important. But also, we also know that sometimes what we see in the literature isn't always the patient global experience of what's happening. And we'll find that out in a second.
We also know research is carries its own bias.
Exactly.
So, maybe in other countries in the US that you can get unbiased research, but it's very hard. So let me read the results in case people can't see them. 80%.
Oh, wow. Nobody both. Okay, good.
80% had surgically confirmed endometriosis. 100% had imaging. Most had transabdominal ultrasound, and 30% had both transabdominal and transvaginal. And what I find interesting, and I wonder, doctor, if you find this interesting, 60% had MRI. Yes. And then I think about how the majority of our viewers are not in the United States, because to get MRI approved is very, very hard.
I'm surprised that TVS on its own has it. That's what I thought would be so far. But again, this is small because not a lot of people can vote. So
so imaging and diagnostic laparoscopy is what most people had. And most people did have deeply infiltrative endometriosis. 20% had peritoneal disease. 20% had surgical diagnosis, but don't know what types. And we can talk about how we feel about that. And the reason why we have strong feelings that you should know what's out there is why I think it's so important Wendy did this webinar, because she shows you exactly what's going on with your body. And you have to know, because I feel like the majority of doctors are not specialists like our doctor here. So, and 50% had preoperative imaging to estimate what's going on. And Wendy, you'll know we haven't announced it on Clubhouse. We're going to talk about having a general surgeon in the room, and the preoperative imaging helps prepare the team, right, Dr. Mangeshikar?
Absolutely, yeah. You nailed it. It's all part of the preparation. You've got to be prepared before putting a scope in.
Yeah.
Number 6 is very, very important.
All right. So I'm turning off my mic and letting the fabulousness continue.
Thank you for
I did my part. Your turn again. I think. Where are we? Go ahead on to the next slide, I believe.
Yeah. Let me get back to the presentation.
We'll have to figure out how to get these polls out we've got to find a way so that we can get that participation. I would really, really like to see the individual voice. I think it's really important. What's preached to do, what is the gold standard on how to approach the disease clinically, but what's going on. And it is subjective. We have to go by the patient and what they remember, what they think. So we know that there is some possibility of error there, but it has some substance to it. Anyway, okay, I'm shutting up. You go ahead, Dr. Abhishek.
This is a great note to kind of segue into imaging. And I think this is just the start of the conversation. As Dr. Sorrell mentioned, that we should, conversation needs to recur, and we need to get a lot more
louder
and pay attention, and yes, make it a little louder. So let's talk about imaging. So this is an interesting topic for me because I can give you a brief on how it started. So when I was growing up and in my formative years as a medical resident, and I traveled to conferences, and you see these big endometriosis surgeons doing these radical procedures, and there was not a lot of similar diagnoses or procedures happening in India. And I was saying, okay, obviously it's not just located to disease in Europe or North America. So there is obviously something happening here. So we need to improve the diagnosis to be able to kind of improve the surgery. So that taught me to kind of do my own ultrasound and also read my own MRIs, because not all imaging is equal. It truly is dependent on who is performing the ultrasound and who is interpreting the MRI. I've had MRIs come in with a huge nodule in the rectum, which said rectum normal. And I have to write back to the radiologist, and we have a discussion about that and a little further study with a gel in the rectum to kind of correct that. But it's obviously not possible to do that in every case. And also, it's interesting that we mentioned in the polls that MRI is higher. And of course, there's a geographical variation with this. In India, of course, MRI is also expensive compared to ultrasound, but marginally so, not too much. And it also enables me to make a diagnosis remotely, because I cannot have a patient fly into Mumbai just to undergo an ultrasound and then fly back while she's waiting for surgery. So she can get an MRI done at her radiologist and then send me the files digitally, which are very standardized, and I can interpret myself. Or if I have a doubt, then I send it to my specialized radiologist, who can make a better diagnosis there. So I think there was a very good paper by Chuck Miller in the AAGL journal. It's not only about the song, but the singer is also important. So it's not just about being in the right place at the right time. You have to be the right person to be in that right place at the right time. So I put this slide up to talk about ultrasound for endometriosis. It's a busy slide, but this is the protocol, kind of based on the IDEA protocol and the groups that do ultrasound for endometriosis. So when the first two plots of just the uterus and the ovaries are what a standard ultrasound report of the pelvis comes in as. When you get a TVS done, these are the only two structures most people will look at and comment on. So the rest of this is not necessarily reported in most ultrasound centers. So one, if you're a gynecologist and you have, I don't know what the privileging is in different countries, but if you can do your own ultrasound, you should, or you should work with someone who is skilled in endometriosis related ultrasound. That being said, ultrasound is not the final diagnosis. Imaging, ultrasound or MRI are going to pick up deep disease. It's not going to pick up peritoneal disease. And we know that density of disease is not proportionate to the amount of pain a patient feels, especially peritoneal quality of pain may be much higher and much more acute than someone with chronic pain from a deeper, larger nodule. So just to go over this quickly, for the uterus, we look for adenomyosis. We check for retroflexion, which is when it's different from retroversion, which is when there is disease at the back of the uterus, which is kind of pulling the uterus onto itself. For ovaries, apart from the endometriomas, which are the most commonly diagnosed in all ultrasounds, we look for fixity of the ovaries. We look for thickening of the tissue below the ovaries, which would indicate adhesions and uterosacral nodules. And also we look at the anterior compartment to check if the bladder is fixed, and we look for nodules. And if you trace back along the bladder, you can catch the ureter in cross section and trace it down for hydroureter. Conversely, if you do look, you should always do an abdominal scan to look at your kidneys to make sure you're not missing a hydronephrosis. And then it's important to put the probe behind the cervix and look at the fixity of the rectum to the uterus and whether they move independently of each other or if there's adhesion or nodularity there. And it's important to report on these in 3 dimensions, so that gives the surgeon the knowledge he or she may need to go into surgery. So like the highest bodies of evidence usually look at the greatest pool of data. And like most Cochrane reviews, it says that all methods are equal and we need more data to reach meaningful conclusions. So, but that really doesn't mean anything in reality. And I think Wendy has elucidated that brilliantly in her visual slides. And so these are just some examples of disease when we look at them in different modalities. Of course, I have demarcated them so to make it easier to understand. We don't have this luxury during investigation or surgery. So this is the ultrasound first with the same nodule that you see in all 3 images. And this is where I also had an MRI done before the patient came to see me. So this was the nodule on the back of the uterus over here. This is the bladder in white, that's the tailbone, and this is the rectum behind it. So the nodule is infiltrating into the rectum. And if you see this line here, this is the normal rectal muscularis that is fall down. And this is how thick the muscularis has been infiltrated. And when you see a cut section through the nodule this was a disc excision. This is about a 3 centimeter nodule, so we're right on the margin there. This is the nodule exactly in the same horseshoe pattern that we picked out on imaging. That's a vaginal implant where you see it had grown into the vagina. So that was confirmed by a speculum examination and clinical examination. So it's not one method over the other. It's using whatever modalities are available to you and making them all equally to your benefit. Sorry, I've lost my sharing.
I was gonna say, we're done already? Wow, that was fast.
All right, we're back.
Yeah.
And in this case, there was a double horseshoe. So you see 2 nodules in the rectum here. So this whole thing is the rectum down here. And these are two nodules growing into the rectum and the vagina as well. And you see the same thing on the MR imaging, the two horseshoes. And when we did obviously these cases do require segmental resection. So you can see exactly the two nodules, one after the other. They're too far apart from each other to even attempt to do two disc resections, which I'm more comfortable doing a segmental resection for this kind of case. So when we come to treatments for endometriosis, and these are a lot of questions that have come up in my practice, so I thought I'd share it. So what I frequently get is, do I need a hysterectomy? So in the absence of uterine pathology, and there's no pain emanating from the uterus, a hysterectomy is not a useful treatment. I always break it down as like, if you have appendicitis and if I remove your uterus, you still have appendicitis at the end of the day. The same thing applies. If you have bowel endometriosis and you do a hysterectomy, you're still going to have bowel endometriosis. You're still going to have bowel symptoms and possibly the sequelae associated with bowel disease, which can be catastrophic if they do progress to create occlusion or to create irreversible nerve damage. And of course, when we look at statistics, the retreatment rates for patients undergoing hysterectomy are significantly high. When we do talk about fertility from endometriosis, a lot of them are led to believe that they need IVF. And this is a great slide from Horace Roman. And the patient is presented with the clinical scenario where she is given Sophie's choice. Do you prioritize your pain or your pregnancy? And the patient, in a benevolent way, putting family first, would say, I want to get pregnant, of course, and I'll deal with the pain later. So rather than addressing the focus of the disease, she is directed toward multiple IVF or ART procedures, which we know in the presence of disease has much lower success rates than standardized IVF procedures. And this led to a great study by Professor Roman, which looked at his series of patients and recruited them to undergo excisional surgery. And he studied the outcomes of pregnancy outcomes, and 80% conceived within the first year. And this was some 450 odd patients. And out of those 80%, 60% conceived naturally. And this was all for colorectal endometriosis, not just endometrioma. So this was bowel procedures, bowel resections, discoid excisions, and shaving procedures. These were the cases recruited, and the removing the disease automatically improves, reduces the inflammatory processes and would improve the environment to help pregnancies. We also want to know why medical therapy fails, and medical therapy is directed towards symptomatic relief. It has nothing to do with, there's no evidence showing that medicine, whether it's hormonal or pain management or GnRH agonist or homeopathy or Ayurveda or acupuncture, has anything to do with reducing disease focus. So the volume of the disease is never reduced by medication. It does suppress hormones, which may reduce the estrogen-related flare-ups that are present within the disease. But it does not, there's no evidence to show that it slows down progression of disease or the regression of the disease. So I'm hoping this one disappears and is relegated to history, but we know that pregnancy doesn't cure endometriosis, and just like whatever hormonal medication is out there, it works in the same way by keeping the patient amenorrheic and suppressing hormones, which is in the past.
Wow, so this is a really good topic here. I want to go on to this, but before we do, are you able to, Abhishek, can you go all the way back up to where you saw the cross section for shaving, discoid resection, that beautiful cross section that had the lines through it to show you the layers of the bowel?
All right, sure.
I was so excited that he was able to find something to include in this presentation, because it's really helpful, because we get a lot that say, well, I had a colonoscopy and they didn't find anything. So for people to really see that inside of the lumen, that the bowel can be very, very thick, that this is why when they see a laparoscopy, often they don't see anything. Now we do have people, a very tiny percentage, as Dr. Abhishek will tell you as a surgeon, that have full thickness invasion. What would you see if you were doing a colonoscopy and you had bowel endometriosis that was pretty deep, but it didn't penetrate? Knowing that it has a tendency to be very fibrotic, what would you expect that could possibly be seen in colonoscopy that would alert a doctor who's doing a colonoscopy that there might be endometriosis affecting the bowel?
Yeah, that's a good question. So colonoscopy is not part of the routine workup for bowel endometriosis patients. So I don't advise it to my patients to kind of plan surgery. The patients who have had a colonoscopy before coming in to see me, have never found anything. So I have no experience with positive findings on colonoscopy. But what we have read in journals and the case publications is that some expert centers have noted that there's a small protrusion of the anterior wall, which query could be endometriosis. And even fewer have actually reported finding the intravasation of the nodule into the mucosa. So the blue purple dots of endometriosis, I've never seen it inside during a colonoscopy, but there are very few reports about it. So as a rule of thumb, it's not a very useful procedure to undergo for diagnosis.
Have you ever encountered any like fibrosis that has created like localized constriction through the lumen? Have you seen that from the fibrotic process?
Yeah, absolutely. So it grows in the muscular layer. So when it does progress inward, it kind of reduces the volume of the lumen. So a lot of these patients suffer from constipation, and once the stool gets impacted there, it kind of liquefies, and that constipation is followed by diarrhea. So that is a very dangerous warning sign that it's subocclusive disease. And especially when the nodule grows from the top and kind of encircles, constricts the tube of the rectum, which
so you would expect to see a change in the stool, the shape of the stool, as well as the consistency. And so these are other signs for them to think about reporting. It's not just, I have constipation, it's really painful, but are you having a change in your stools? And Dr. Sorrell can probably, as a pelvic floor PT, go on a little bit about that.
Well, I was gonna go on a little bit about that, because that's exactly what happened to me as a patient. And so I had like 500, at least 3 colonoscopies, but on the last colonoscopy, the doctor randomly took a photo of my colon to show me that everything was fine. And the endometriosis surgeon picked it up and said, the shape is wrong. Yes. So while the inside of your gut looked fine, the shape was wrong. It's exactly what the doctor is describing. And I was basically oval instead of being a circle. And then what would happen was you get intermittent constipation. And then Dr. Jalumba and Dr. Shinovo have talked about how the person's peristalsis is working so hard that once that piece clears through that area, you then get a rush of diarrhea. And then there's all sorts of things with the pelvic floor that cause constipation and diarrhea. But what I like to say is that too often we assume somebody's constipation is only from their pelvic floor. And if you have this business where the bowel is narrowed from the endometriosis, you can have all the colonoscopies you want, but unless somebody who knows what they're looking at looks at it, you may be being misdiagnosed. And as someone who's been through it, those are years of my life that I would like back. Forget the infertility and the pain. I must have spent $50,000 to $60,000 and whatever practitioner could give me something so that I could get out of the house and get to work without diarrhea or bowel. You know, you start with, you start with every practitioner, every herb, every diet, everything. And I think like we need to do a better job. That's why it's so important what you're presenting today.
So educating the people performing colonoscopy isn't just like, okay, the coloring looks good. There's no polyps, there's no this, there's no that. But as you say, just the contour itself, localized restrictions, these are things that are telling you that there's something that's external that hasn't come through all the way through the bowel that's going on.
Right now, I've interviewed Wendy on the other side for people who do the endoscopy. And I work with a GI who is very endo knowledgeable because he's related to 2 endo specialists. And he says when somebody has diaphragmatic endometriosis, that's pretty bad. You can actually see certain kinds of damage to the esophagus.
Yes.
Not necessarily damage, but changes. And he gets frustrated because he's the only one sitting at the GI conference talking about that.
Can he come to do the special thoracic endo thing I'm going to be doing in a few weeks? Because I talk about there's gastrointestinal with the diaphragm and its role in the GI and the GI symptoms that you have with the disease. I mean,
well, he's going to do the podcast, but I will connect you.
So then our next thing is Abhishek. I had somebody in my group that posted a question. She said, you know, I had a discoid resection of my bowel. And she said, I just had a colonoscopy and they found polyps in the exact location where I had the resection. And she said, do you think that's endo? And so we were like, well, you know, it doesn't happen like you don't usually, endo presents differently, because she said, maybe I ought to have that tested. So, you know, I pondered in myself and I started looking through the literature on it. And believe it or not, I pulled up a few cases that have had individuals that developed polyps in the location corresponding to where they had endo on the outer surface, which is really, it fascinates me because it talks just about the whole remodeling. The body is remodeling, and this is on the interior surface. So while you're healing on the external surface, it causes enough stimulus to create maybe some hyper cell reproduction in the area, and she developed polyps. So I was really fascinated by that. That I was like, well, what's the odds of that happening? I'm like, okay, maybe it's 1 in 100,000 people that you happen to have endo in that area, and you develop these afterwards. We have a colonoscopy that wasn't there before. And then I find out through the literature, there's actually been publications on it. So anyway, I wanted to throw that out there for people to see that and talk about this section with this cross section, because like I said, this is what I've been wanting to see really badly and communicate to our audience about disease and the layering that's involved, so that they have a better understanding of what happens and why you can't see it in a scope. So thank you. Where do we go? We got to go fast forward all the way down to the bottom, and our last bit that we were just, our observations that are.
Yes, while we get there, I mean, a discoid resection is full thickness. So there's a remodeling happening at the mucosal level.
Okay.
So there's going to be fibrosis and fibroblasts and a lot of changes happening there during the healing process, which could very easily lead to a prolapse of a mucosal polyp.
Yeah, very
Makes
interesting. Sense. So I'm glad that we talked about that. I learned something new when she posted that. It just bugged me. I was like, I have to go look and see if there is something on it.
So before we switch over, one of the important things I wanted to touch upon with bowel endo symptoms is the one symptom you really do need to watch out for is dysuria. And no, this has nothing to do with bladder endo. Yes. If there's a bowel nodule and the patient has dysuria, and by dysuria, I mean that the patient needs to compress the abdominal wall to empty her bladder, and it takes her inordinately a long amount of time to empty her bladder. This is involvement of a rectal nodule that has compressed or involved the sacral nerve roots, which supply the bladder. And if you do a bowel resection in these cases, you need to tell the patient that they will need to probably self-catheterize for some time till the bowel regains its function, until the bladder regains its function. Because if the patient is not ready to understand these risks, you should probably look at a more conservative procedure and maybe even discuss the option of leaving disease behind in that case, because it's very important to be able to communicate that pre-operatively rather than post-operatively. All right.
You know, it's fascinating because physical therapy actually has a word for that. When you're having to, say, bend forward and you apply pressure to complete voiding, it's called the Credal maneuver. I don't know if you'd heard of that, Sally. It's an old term. My neurology professor told me that one. It's called the Credal maneuver.
Yeah, I was gonna say that's usually in a neurogenic
Yes.
bladder. But I have to say, I've had, first of all, we were just about to launch a whole bunch of stuff on Instagram next week on those nerves. So don't think I'm stealing from you. We had it.
No, I'm glad he brought it up.
Thing
That
is,
was in my head to bring it up.
I had Dr. A very aggressive surgeon on one of my patients really go too deep on the patient and never tell them, and he caused just a little bit of hypogastric plexus nerve injury, and she burned and had bloating for the rest of her life. I mean, she ended up putting in a device, I think, but she burned and had bloating the rest of her life. So it's you have to tell the patient what the risks are, because ultimately the patient gets to make a choice. And this is, and also, like, obviously our doctor here today, he knows what he's doing. He's a rock star, but that was like a local GYN that tried it on a patient when he saw it in there. That's maybe not work you want to let somebody who's not a specialist do.
Well, and Abhishek brought up is such an important point that if you say, if an individual has bowel disease on their bowel, that they're scratching their head going, well, why is it affecting my urinary system? Why is it affecting my bladder? It's on my bowels. And so understanding that, you know, there's a plexus, and that's an autonomic nervous system, and it impacts both. The way that the innervation runs is really, really important for, I think, our community to understand that, and just be aware of that. So that leads us into a more fascinating, we wanted to end the discussion with Dr. Abhishek and I, we were talking a little bit about regional variations in disease and what we see, what I see in the literature, as well as just observations of traveling around the world, traveling around within your own country, things that you see. We know, obviously, we talk a lot about differences in probably genetic impact, so gene expression mutations. We talked about maybe exposure during fetal development to toxins that are out there. We also talked about, we all are aware of, you know, toxins in the environment that we're exposed to that can be ongoing and affecting disease, what we eat, what we drink. So all these things can impact the disease, whether it's formation of the disease, laying down the disease patterning, because it's still enigmatic. Can you share, Dr. Abhishek, your experience of going around India with your father in your youth, or in your years of training, and what you saw from a regional difference? And that'll tie us into other observations that other people have commented in, that I'm aware of.
Yeah, sure. Of course, my father, Dr. Prashant Mangeshikar, has a huge experience of some 40 plus years, and he kind of pioneered laparoscopy in India. So he had the luxury of traveling all over the country and operating at various centers on various populations. And of course, he did find a pattern where along the coastal belts of India that there was much more significant posterior compartment disease. And this is just observational. We don't have a great deal of data on this. And of course, the theory is because of the migration patterns across history, when the India is a peninsula, so when we were invaded from the north, the original inhabitants started to move outward and downward towards the coasts and the south of the country. So that could explain a genetic variant or mutation. And I mean, it's obviously for something to consider for future studies by people much smarter than I am. I'm just a surgeon. And as my mother, who's an anesthesiologist and a physician, says, you probably use only one side of your brain and your spinal cord. So this is much more important for, I think, the epidemiologists to look into.
Yes.
And
when you mentioned posterior compartment, for some of our people that are viewing, what areas would you consider that to be?
So behind the uterus and between the uterus and the rectum, kind of bowel disease, uterosacral disease.
Yes. And then when we were looking at, I attended during Awareness Month in an event that was hosted in Nigeria. And it was very interesting that one of the surgeons there had made a comment that what they see, they actually see a great deal in her clinic of primary cutaneous umbilical endometriosis. And this is on individuals who've never had surgery. They're young, they've never carried a child. And I thought that was really interesting because a lot of places like in the United States, doctors, I hear a lot of doctors here that are like, well, I hardly ever seen any. I've seen lots of scar disease, but I've hardly ever seen any kind of primary cutaneous disease. And then that brought me to the aspect that when I look at the literature and I look at who's publishing it, and in Korea, there is a tendency, and it's not one center or one group of researchers that are publishing, that I see a lot of catamenial hemoptysis being published out of South Korea. And in Japan, I'm seeing a lot of catamenial pneumothorax. And again, it's just observational. Is it that they have this interest? The researchers have this interest, so they're putting that information out there in the public, or is there a significant increase in frequency in that area? Then Dr. Sonarvo recently, I think he was on the Endometriosis Summit, was talking about in people of African descent, that there's more hemothorax events than pneumothorax events. So these are all things that are just observational, but they're, in particular in extrapelvic disease, we're not even getting enough tracking of the disease, let alone to really look at the intricacies of the disease itself and where the trends lie. But these are all things that I just thought it would be nice to close with something that you've just observed. And it puts that question out there just a little bit more. So thank you. I think we're done apart from questions, right? Got a few Q&A.
We have lots of good questions though.
So, well, let's start first. Can I do these, Sally, first before we do Facebook?
Sure.
I'm going to shout this out here. Now this thing on my computer.
Well, do you want me to read them to you so you don't have to worry about it?
Oh, I have the Q&A ones. I'm good with that ones. So it says, my MRI shows my left ovary adhered to my rectum. Is this bowel endometriosis? And this was 8 months post-excision MRI.
Okay. So this is a difficult question to answer because the reporting is inadequate. So it may be adherent to the rectum. Is there a nodule in there? Is it invading the muscularis? So like I said, it's important to look at the images yourself until we have the standardization of the language that, okay, I need to know how big the nodule is. I need to know if there is a nodule or if it's just adhesions. And two is how deep into the muscularis it is and how far away from the anus it is, the anal verge. And So I think that's really important that we standardize the language. Until then, we're kind of stuck to dealing with looking at the imaging ourselves or with our own specialists.
So you think she should go to see her specialist, and she'd had excision, it looks like, that she should refer that information back to him or her or they?
Yeah.
Okay. Good evening. If I may ask, good evening. So this is somebody, it might be in India. Why are adhesions so common with endometriosis? Ooh, what really causes this response? Oh, that's a two-part, really good and bad stuff.
Right. So think of endometriosis. It's like, so within the body, something bad has happened. And what usually happens when something is bad, that immediately a crowd forms around it to see what's going on. So there's the insult of the disease that happens on the peritoneum, on the rectum, on the back of the uterus, wherever you want. And the immediate response of the body is that, okay, something bad has happened, let's investigate. And when there is, the response is to cover it up. So the organs that are closest usually go and cover it up. So in the case of rectocervical or disease on the back of the uterus or in the vagina, the rectum is the closest the closest organ around, and goes and covers that insult. And in the case of the ovaries, they get stuck to the pelvic sidewall or to the back of the uterus because of the disease, the adhesions that form there. I mean, of course, I'm really dumbing this down. There's a lot more biochemical and physiological processes that happen that cause adhesions. And also there's variability in adhesions. So when you talk about endometriosis having genetic and epigenetic factors, so two identical twins may both have endometriosis, but they may have different presentations of endometriosis because of their genetic sequences. And that may have a role to do with why someone may have more severe adhesions, whether if it's from disease or from surgery. Of course, as surgeons, we do our best to minimize that we have as little bleeding as possible and as few raw surfaces as available. But endometriosis is messy surgery, and you have to kind of adhere to the cleanest surgical principles and respect the tissue. But someone who may have the messiest surgery may respond with the fewest adhesions, and someone who's had clean surgery may develop much more severe post-surgical adhesions. So of course there are many adhesion prevention barriers which are from the pharmaceutical companies, but till date there's no evidence that any of them are better than the other, or if any of them are better than no adhesion barriers at all. I think that's another topic for another discussion in surgery in general. But as far as we know, that adhesions from endometriosis are because of inflammatory processes, and adhesions from surgery come down to how you heal from surgery and also surgical technique in a nutshell.
Right. And I look at it, it's interesting with endometriosis and, just being a physical therapist and injuries and how our body heals from a PT standpoint and tissue gliding and mobility. You have the factor of the individual's body. Some people are super healers and over healers. We over heal our body when there's an injury. Woo, our body jumps on it and wants to heal. And unfortunately, it can overheal and be overly aggressive. Then we have the endometriosis itself, which is such a fascinating disease from a molecular level, that the endometriosis itself reduces the amount of Pac-Man, white gobbly cells that go around, the little Pac-Man that clean things up. And so there's that interaction with part of the immune system, not as an autoimmune system disease, because that's when our body attacks its own natural cells in their own proper location. Here we have a disease that is not normal for the body and not in a good location, but it's affecting the disease's ability to produce those Pacman to clean up that area. So here's our immune system constantly trying to heal that constant inflammatory state. So those are things that I like to try to describe. I see hands going up there. Hi, Sally.
Okay.
I got the window.
I just wanted to say, for people who are really interested in adhesions, Dr. DeLumba, who is our adhesions. I mean, he's fantastic with adhesions and he studies this and that's his passion. And everybody has their own passion. But if you look on the Endometriosis Summit YouTube page, and you have to go way back, it's one of our first YouTubes we ever did. So he was standing in a bar and talking on his cell phone. So the sound is terrible. I warn you on that. But he talks about adhesion formation almost being a response like when you knock a can of soda and everything bubbles and ferments. And he has this whole other theory. Yes. So beyond that, just touching it in certain people develops a cellular response that is not developed in everyone. And then while it's not up on YouTube yet, Dr. Young took that a step further at this year's Endo Summit to talk about there are some people who are adhesion makers and who aren't, just like our doctor here today just mentioned that. So if you really want to learn, it's very involved, and maybe like Wendy or I, we could have Dr. DeLumba on one of these to talk about adhesions, but adhesion development is super involved. And then if you were to talk to some of the reproductive immunologists, they would say there is this entire inflammatory response that we don't understand to surgery. You know, it's a very deep thing.
So that'll digress us right into the next thing, as you mentioned, Sally. When we talk excision, what is driving the inflammatory status? So there's always that question, oh, where's the pain generating from? Well, we know a lot of the pain is inflammatory. And when you remove that inflammatory aspect, you change things, and removing that disease from the inflammatory aspect by cutting it out, not burning it and leaving it behind for the immune system to continue to attack, you're taking at least that factor out of the disease.
Well, I would say, and actually it's funny you mentioned your mother's a anesthesiologist, but pain is multifaceted. And so inflammatory response and pain generating are actually two separate things, but you often cannot make progress with what is generating your pain if you have this big wad of inflammatory cytokines and junk sitting. You can't rewire the brain. You can't do any of the things that need to happen. Yeah, but pain generation is, we could be here for 4 days on that.
Yep, we sure can.
Can I ask a question? You both are in-house physiotherapists. So I was on a panel with a bunch of pelvic physiotherapists in India, and they asked an important question: Does pelvic massage help with adhesive disease? And I mean, we couldn't reach a good answer on that because there's no data, and it's all personal experience. And I think you guys have great experience with it.
So there is some limited data that in mice who had abdominal surgery, so they had tummy aches, and then they had in mice who had abdominal surgery who received visceral manipulation within, it's been a while since I read the study, within a certain amount of hours post-surgery, you could change the outcome of adhesion development, right? And so there's that one study that isn't I hate this. You see it on Instagram all the time. Breaking my physical therapist broke adhesions. You are never breaking an adhesion through physical therapy. In fact, you could be making them worse if you're using that much force. You're gonna, it's just like everybody likes to see the crowd when there's trauma there.
Exactly.
What you are doing for the most part with physical therapy is changing not only the proprioceptive input to the brain in the area where the adhesion is, but lengthening the tissue around the adhesion so that
remodeling, stress lines.
You may feel better. Now, there is a book by Belinda Wern who talks about, and that's their area of research, who talks about adhesions in physical therapy, and they've done some of their own research. I think they're in the process of publishing. And so there is some talk about visceral manipulation having more of a bang for the buck in terms of adhesions and what it does. But that's not pelvic massage. So it depends what technique you're using. And then the other thing is, it depends on the quality of PT. If you have a PT who's seeing one patient a year, which is like maybe 50 hours a year, versus somebody who's doing 50 hours a week with endometriosis patients, you're going to have a very different skill level. So the consensus, so we tried for a long time, do your pelvic visceral manipulation within the first 48 hours. And then I went and watched one of these surgeries, and it's like, no way is that safe for these patients because it's minimally invasive, but it's maximally involved. I mean, what you guys do as surgeons, people cannot appreciate the intricacies of that. So my consensus is that it changes the proprioception to the brain and it lengthens the tissue around it, and the patient may feel better. But no, I don't think it's, unless it's done so early on, I do not think it's breaking an adhesion. And then it depends on the technique that you're using.
Right. And when you think, I'm not as a pelvic PT, as general tissue healing. So as she says, is the technique, the amount of force, obviously, because too much force can just aggravate the situation and facilitate further. It's the direction that it's applied. In the old days, it used to be transverse friction massage, right? Tendons, transverse friction, it's going to increase blood flow. It's going to break adhesions. Now it's actually, no, we use things like gua sha tools where you're going along, you're breaking little micro injury.
Right, but the difference between gua sha or Graston or any of that is those are superficial orthopedic adhesions. That is not like what somebody has. I mean, that is not an ovary attached to you're never getting deep enough. You really can't.
But the concept
deeper than 6 centimeters. With
the concept is working along the lines. There's certain, like I said, visceral manipulation of ways that you know that you're going to facilitate bowel mobility or whatever. You're working along certain stress lines versus just getting in there and moving around. I mean, there's an art form to it.
Right. So. And orthopedically, like I know with Wendy and I could do this for an hour, but orthopedically, Wendy, you can remember when people used to have knee replacements, you had them in the machine right away because you don't want them to get an adhesion. And what I found as somebody who's switched from orthopedics to pelvic health is like the way people develop adhesions are super different.
Everybody's different.
We can't even use the orthopedic research. It's really hard.
No.
So scar tissue, like I've seen people who have like the trocar scars adhesed. Yeah, you can make a lot of changes in that, but inside deep rectal adhesions, it's really hard with that stuff. And so I have also seen people who have like almost a frozen pelvis post-op who go through a lot of physical therapy and lead an amazing life because we've taught their body how to adapt. Now, is that going to happen to everyone? No, but it does happen to some.
Yep.
I know. Can of worms, doc. Can of worms.
Yeah, don't open those. Okay. So the third question is how fast does endometriosis progress in the bowels and urinary tract? This kind of goes along with what we were talking about, the regional variations in genetics. So let you answer that.
Yeah, that's a tough question to answer because usually it's one, you've got to have standardization of measurements over time, and that's not going to happen. And then you want to see, so I mean, I can answer this more experience based, where we had this was actually one of Professor Roman's patients where he had shaved a nodule and left something behind and monitored that up progressively, and in 2 years she went into subocclusion. So that was but when you shave, you're taking off the top of the disease, so the bottom of the disease is already into the muscularis as low as it has already gone. So, and it doesn't really spread like metastases like a cancer, but it kind of locally infiltrates at where it's at. So it's bowel disease is usually either going to grow down or going to grow laterally. So either way is not a good outcome. So and urinary tract, yeah.
So I
Sorry.
think that also you have the difference between progressive and non-progressive disease, right? And we still don't know. Some people it progresses very fast. Some people have non-progressive
Exactly.
disease. It's just it's always there, but it's not going anywhere, right?
Yeah.
Now you've yet to determine how can you determine one versus the other, right? Is there a phenotypical variation to it?
That's right. Yeah.
Sally, do you have questions?
We have some questions off of Facebook. This one's a little, we have good bowel questions, but I want to ask this because I get asked this all the time as a physical therapist. What are the advantages and disadvantages to keeping or losing the cervix at the time of hysterectomy?
That's a good question.
Great question. Okay. So when you retain the cervix at the time of hysterectomy, it's called a supracervical or a subtotal hysterectomy. And removing the cervix is called a total hysterectomy, laparoscopic, abdominal, or robotic, or vaginal, whatever you do, the root of the hysterectomy. Now, in a situation of endometriosis, and when you have disease of the back of the uterus, which is the cervix, it is almost, in my opinion, almost criminally negligent to leave the cervix behind in these cases, because you're leaving a lot of disease behind, and the person who has to go in after you to remove that cervix is going to have a nightmare of a time trying to what is called a trachelectomy, to remove the cervix and the parametrium and also deal with the rectal and the vaginal disease in there. So for just adenomyosis, supracervical hysterectomy, or fibroid, supracervical hysterectomy is okay. For endometriosis, in my opinion, it's a no-no.
So I speak as a physical therapist and as a person who has a uterus, and even though the literature may not have caught, and as someone who was heavy most of their lives, the literature may not have caught up so much on it, but you are at a higher prolapse risk without the cervix. So it depends who's putting out the research. The physical therapy crowd says one thing and the surgical crowd says one thing. And I think most physical therapists that you talk to, if the cervix is gone, then you're at a higher prolapse risk. Most surgeons you talk to say it makes no difference, and the research reflects that conversation. And so if somebody is extremely athletic and they're at some risk, you may want to do prehab. So that means making sure everything is working the way it can be before surgery, so that you can have the choice that's best for your endometriosis and your adenomyosis. And the other thing is, you may be the patient that accepts that you're going to have an incomplete surgery, and if you had to go back in, it's going to be a nightmare. And then the other component of it is, we do believe part of orgasm comes from the cervix, part of the twitch response comes from the cervix, and some people are not willing to give that up. And again, you have to have these conversations with your doctor on why or why not. And what I tell people is, if the doctor is not receptive to this conversation, you may need to find a new doctor. So if the doctor only wants to say, I only take it out because that's what's best for the endo, then it's not personalized medicine, right? And so it may be that you need to hear, and while you're in that experience, while you're talking to the doctor, you two need to discuss what's right for you, and not just what's right when you open a textbook or what's right when you open a research article. And you need to understand what may be good for disease may have a different impact on the other area of your life. And so that's why I always think it's important to ask that question when it comes up, because we want to hear both. We want to hear everything there is to know about it, because too many patients, somebody PM'd me and the doctor didn't explain why they're taking the cervix. So she walked out of the office and said, no way for you. And I said, but did they explain that you have adenomyosis and this is what could happen. Did they explain this? Did they explain that? And then she's still not using that surgeon, but she made a different decision. So you have to have that informed consent specifically on the cervix, I think. Yeah. Do you see, and it depends. I mean, connective tissue is different around the world. Have you seen a lot of prolapse, doctor, without the cervix?
So in endometriosis patients, no, because there's a lot of fibrosis. I have 2 cases of nulliparous prolapse, but not with no endometriosis. And there are certain other factors that do cause it. But on the whole, I think at least what the surgical community agrees upon is that when you do a full closure, you kind of plicate the pelvic floor, including the uterosacral ligaments in your bite. So that creates a high vaginal vault suspension. The data on sexual function after subtotal versus total hysterectomy is not conclusive. So you can use the data to suit your argument or your practices. And in India, there's very poor cervical cancer screening. I mean, so like my father always joked that because he kind of did the first laparoscopic hysterectomy in India after Harry Reich in the States 1 year later. And somebody in the audience asked him, why don't you do supracervical hysterectomies in India? So he said, as a show of hands, how many gynecologists in the room have had a pap smear in the last year? And maybe 2 or 3 raised their hands. So yeah. The programs for cervical cancer screening are not great. So in the whole country, it's the patient follow-up post-hysterectomy is not going to be that efficacious. So I think the guidelines would be more towards favoring removing the cervix if you're doing a hysterectomy.
You know, that is an amazing point. And I know when I traveled throughout China, they take the cervix because the way the healthcare system works is really once you've had a hysterectomy, you're never going to be able to get another doctor's appointment for a screening, or it's very hard for pelvic pain patients who don't have a uterus there to get appointments. So that is an absolutely fascinating point. Very, very good.
You both now just triggered another thing about when you mentioned removing the uterus. Let's say you remove the uterus and the cervix. Let's say you remove the ovaries too, and you have endometriosis still in your body. We see this a lot. A lot of this goes on in our group. People are like, I can't get anybody to even take me serious about my endometriosis because they said I don't have any female parts left for treatment. And this is a common conversation that comes up, and it's very sad because if we had more people that at least healthcare providers that were aware of this to say, let's get you to an endometriosis specialist, because we do know disease still exists, whether you have uterus or not, or ovaries, that it's still a problem for a percentage of our population. So side note.
I mean, I also think that's why, first of all, webinars like this are important because the two of you are showing just how much is not related to the uterus, but the conversation about imaging also becomes important because you have amazing skill to read imaging, but eventually if we keep talking about it, it has to trickle down to radiologists, because then you can prove, no, here it is. Here's the disease right there. I just happen to think that that's 10 to 15 years away, but other people think differently. Yes. So we have another question from Facebook, and it is, how do you tell the difference between IBS and bowel endometriosis? Yes. And why do doctors only consider bowel pain to be IBS?
That was something we were supposed to include, but it kind of, yeah, go ahead.
Yeah. IBS is the most common misdiagnosis for bowel endo, and it's very interesting and easy to kind of pass the buck onto another specialty because IBS doesn't come under the realm of gynecology. And it's very easy to say, if you don't know how to do bowel endometriosis, refer to GI or whoever. And I think, well, for bowel endo, imaging is really good, especially if you have access to the imaging to make the differentiation. And even superficial bowel nodules, if you kind of pay attention to the patient's symptoms and there is evidence of endometriosis elsewhere, and you do a scope and remove the nodules superficially over the serosa, that does produce a reduction in bowel symptoms as well. Because it's not necessarily just the deep nodules that cause symptoms. The inflammatory processes do kind of cause a hyperstimulation of the plexuses of nerve around the bowel that produces a hyper response, which leads to stuff like the endobelly and food sensitivities and stuff like that.
So if you were to say, as we say with IBS and bowel endo, say we know that diarrhea, constipation, bloating is very common, even if you don't have bowel endometriosis, but you have endometriosis, that noxious stimulus. Do you have something that you, and a patient comes into the clinic, that really makes you lean towards bowel? The bowel is directly affected. Are there certain things you would point out?
Yeah, so that's, again, it's coming down to listening to the patient and just taking it in, writing everything down, don't jump to conclusions, and then relying on putting the whole story together with as much evidence as you can from listening to her symptoms, the pattern of the symptoms, relieving factors, progression of the symptoms, and from examination and imaging, and then of course what you see at surgery if surgery is undertaken.
Okay.
Doctor, I do a lot of work with SIBO. I don't know if you do any work with SIBO, SIBO. The
Yep.
transcription is sort of weird on the SIBO. But I believe, first of all, the endometriosis has to be removed, but that overgrowth still is living within the person. And so you may not have a complete sensation of symptoms. What is your experience with SIBO? And my other experience is not enough patients have heard about it.
Yeah, exactly that. I mean, I've personally had only 2 patients in the last, I'm always referring to things as post-COVID, well, post the first lockdown, we're in the second lockdown now. So I've had 2 patients who were diagnosed as SIBO before, and no bowel endo or minimal, just superficial implants. And so they were undergoing treatment with their gastroenterologists and nutritionists to deal with that. So, but very regimented diets, and unfortunately, none of them were working with the physiotherapist, even though I recommended it, and
Right.
said, okay, we'll take it under consideration. But I would love to hear your experience with this, because it's
I mean, my experience really is 1 in 3 have SIBO, sometimes not like like I have resistant SIBO, so I could treat it, and I have found my triggers, one of which is wine, so that's not so fun. And so I can't add them. I'm not a huge fan. I agree with Jessica Drummond on you can't go total low FODMAP, because that is a good way to develop restrictive eating disorders. But I do find at one point we're testing almost anyone who we suspected bowel endo with, because if you can treat the SIBO before surgery, maybe one time, and then do your good quality excision, and then treat it again, maybe 4 to 6 weeks out of surgery, the person doesn't have to go crazy with elimination diets, and the person could really clear it forever. I think it's the long going fermentation process. But I do encourage everybody who does have SIBO to try to see a physical therapist, because that connection, there's a technique that they can do with the ileocecal valve that oftentimes can help SIBO a lot in conjunction with other treatments. But I think that people who've had really good bowel surgery, and we know the surgeon did not damage the hypogastric plexus or the hypogastric nerve or the area around those nerves, they should be tested for SIBO if they're still getting that crazy endobelly. And I don't always think the testing is accurate, but doctors will argue you don't want to put somebody on that strong of an antibiotic without testing. The other question fits right into this off of Facebook is that could you explain the link between severe food allergies and bowel endometriosis? And you just started to. So now I really want to listen to you. I'm fascinated by this whole webinar. It's the best ever.
I think it kind of ties right in with the SIBO conversation with, so like I said, with endometriosis being an inflammatory process, we know that endometriosis has neuroangiogenesis, which is new blood vessels forming because of the inflammation. But we also have evidence that it produces neoneurogenesis, which is new nerve fibers, and the thickening of the nerve fibers. So they increase in size as well to increase conductivity, which is, so kind of like, it's your body forcing you to pay attention that something is wrong. So they're increasing the bandwidth so you would make it louder. Exactly.
Yep.
So just like, so someone without those hyper response would maybe have a little bit of indigestion with coffee or wine or certain stimulants like that. The person with endometriosis and that kind of inflammatory hyperneurogenic response of the enteric plexuses would have an endobelly with maybe a glass of wine or caffeine or whatever stimulant of your choice.
Do you have any, you'll have to send me some of the studies about that, about the thickening of the nerves and stuff. It makes a lot of sense to me. I mean, we know about the neurogenesis of the disease process itself, but the actual thickening of the nerves and to scream louder, that really fascinates me.
So there were really good presentations in Endo Dubai last year, pre-corona, by someone from Canada, Dr. Paul Young.
Okay.
And I forget, someone out of Michigan, University of Michigan. I'll get you those articles, and we'll put them up for everybody who's interested to read about.
Yes.
I think that's usually Dr. Asani out of University of Michigan.
You're right. You're right. Yeah.
I mean, my only thing is they don't use such a big sample size. And so, I've read some of that anyway. And do the two of you have any more questions?
No, thank you very much for putting this together for me. It would have just rattled my nerves to have to try to figure out all the digital, and I don't have the capacity for closed captions, which I think is really important. And now you know how to use it too. So
now I know how to use it. I mean, my mind was absolutely blown by this webinar. We know that extraperitoneal disease exists, but do we look at the statistics enough? And you can really see, right? You can really see as a patient, I feel that you should be able to walk into your doctor and understand the shaving versus discoid resection, because it's your body and you have to have that conversation with the doctor. And if the doctor doesn't understand it, you have to have the conversation with yourself as to whether or not you want them cutting into you. So if the doctor is not sounding as intelligent as Dr. Mangeshikar, do you really want them cut? I mean, who is as intelligent as he is, though? But it's a very important thing. And I just found this absolutely fascinating. And I want to thank everybody that came today. It is shareable on Facebook. You can listen to it again in the Extra Pelvic Not Rare group, where Wendy will pin it to the top of the page.
Once I figure out how to do
that, we will get copies to the doctor. Maybe you could have it sit on your website or your pages too. And we will also, as a guest post, we'll have it sit on the YouTube for the Endometriosis Summit. But there is information, I do these all day, every day, and there's information here that you can only get here. And I want to just say that this was amazing. And thank you so much to both of you.
Well, thank you, Sally. And like I said, if there's some way we could get the poll out there that is people who can't sit in and listen to it at their own time, because it's a weekend. So we realize people are busy this weekend, and we picked a Saturday because he's available on a Saturday, and the 12.5-hour time change is difficult. But if we could do that somehow, and
Well,
I'm
Wendy, you can poll directly in your group.
okay.
Yeah. So the other thing is we can work on some plugins, but you can poll directly in your group.
Okay.
Also, I couldn't find my Trish t-shirt this morning. I feel so bad.
Okay. Well, Trisha's having a friend, Taylor. We figured out Taylor's going to be joining her soon, so she'll have another infographic with her. I do want to thank Dr. Mangeshikar for being able to pull up non-surgical pictures for us that are really, I thought that, you know, it's hard enough for us, and as he said, as a surgeon sometimes to go, what am I looking at, and have an idea of really what's happening, and being able to show us with those photos, just illustrations, is, I think it's really helpful for our community to really get a good feel of what the process is and what it looks like. So when they have a colonoscopy now, they can look at the transverse cut, or the, you know, the diameter of the colon, and have an idea of, okay, well, that makes sense. So thank you. Thank you.
So hopefully we'll be able to develop this a little bit into a workshop for next year, but we have to figure all that out. It's May. I don't have to really start to think about that till August, but we're going to stop our live feed on Facebook. If there are any questions here left on Zoom, you can put them in the chat or the Q&A, or we'll sign off. But let me stop the live feed on Facebook.
All right. Thank you, Dr. Sorrell, and for allowing us to have this on your wonderful platform, which I'm sure has a huge reach and audience, and helping us get the word out there. And I would love to work together on this in the future.
I mean, I was blown away. So blown away. It'll sit on the YouTube. We had a good following on the Summit page. I think at one point we were up to about, and it's sharing. You have about 30 shares going on. We were live on Instagram for a few minutes, which I think helped, but it really was,
it reaches more people later. That's the big thing.
Right. One of my goal always is that person who's up in pain in the middle of the night, anywhere in the world. Right. I want them to find the information they need. But it's also my goal. Endometriosis is about many, many people and surgeons and practitioners in the world. And so maybe somebody hadn't heard of, well, I feel like everybody's sort of Wendy, but maybe somebody hadn't heard of extrapelvic not rare, but maybe somebody hadn't heard of you, doctor. And I want to provide that because there's amazing care out there, and people should connect with who could deliver it.
And you see a lot, as you said, Canada, Africa, the United Kingdom. You have a pretty big population that comes in when there's no pandemic going on.
Yeah, and I'm still doing remote MRI readings across the pond, so that works.
It's so hard. I'm sorry for what's going on. Although I was in Florida, it wasn't that much better, but I'm sorry for what's going on. All right, I'm gonna shut off our recording.